And our own past president, Dr. Sanjaya, will be taking the session offline because he's working from the US right now. I request Dr. Babu Peter to introduce him. Okay, so he'll join online to take questions for 5 seconds.
Thank you. Good morning, everyone. It's my pleasure to introduce Dr. Sanjaya Vishwamitra. And he has been qualified in the American Board of Radiology, and he has been a chairman, Indian Association of Cardiac Imaging, and head of Department of Radiology, Sri Sathya Sai Institute of Higher Medical Sciences, Bangalore. He has been involved in the cardiac imaging since 2003 onwards, and he has several publications and lectures to his credit, and several scientific posters and exhibits. His main focus is on all forms of cardiac imaging, and his main achievement is that he has been a chairman of a wonderful association and friends with a great group of like-minded and brilliant individuals in the executive committee of IACI and the founder members. Welcome, sir, to give you a lecture.
He's referring to us, by the way.
Thank you for joining the SCMR IACI Symposium. Thank you to the organizers for allowing me to present IACI's efforts in promoting CMR in India. We did a survey from 32 different institutions across India, which, as you can see, are distributed through the entire Indian subcontinent. And the respondees basically had 7 years of experience in about 53%. And the remaining approximately 50% were evenly divided between those who had about 1 to 3 years of experience and 3 to 7 years of experience. Approximately 1/4 of the group did more than 15 CMRs per month, and another quarter did about 10 to 15 CMRs per month. So that's a very heartening thing to note, is that over 50% of these group did more than 10 cases a month. In the remainder of the group, there were only less than 10% who did CMR rarely, with about 20% distribution between 1 to 5 and 5 to 10 per month. So then the question becomes, what type of examinations do these people do? As might be expected, almost the entire group did viability and ischemic heart disease as their primary CMR indication. What is good to note is that over 1/3 of this group, 38%, actually did perfusion imaging as well. And the presence of dilated cardiomyopathy, hypertrophic cardiomyopathy were actually seen in a fair number of these groups. The presence of masses or evaluation of masses was in about 2/3 of the group, and almost 40+% of the group also did congenital cardiac imaging, which I think is again something which is heartening for us to note. The next question then becomes, what is the type of training do these people have? 75% of the respondees had some form of training with the Indian Association of Cardiac Imaging. About the rest of the group were either had no training or had some 15% had training at a foreign institution. I think perhaps what is important to note here is that there are no red parts of this pie chart, which means that there is no other organization other than the Indian Association of Cardiac Imaging which is promoting CMR training, certification, and workshops in India. Regarding the types of training that these people had, we divided them up into those who had no formal training, those who attended basic workshops of less than 2 days with or without workstation support, those who had more than 2 days of advanced workshop evaluation, and who required hands-on workstation as part of this advanced workshops. Fellowship training was divided as 1 to 3 months, 3 to 6 months, and over 6 months of training. And those who had no formal training perhaps also had a large amount of individual experience of over 200 cases per year. And then if you look at the distribution of this, you would notice, interestingly enough, that about 50% of the group actually attended either a basic workshop of less than 2 days or an advanced workshop of more than 2 days. And I guess this is something that we should really consider in terms of where IACI might want to focus its efforts in the next coming year, in trying to improve the understanding and certification and training of this 50% of the delegates, of the members who are also doing a large number of cases. Fellowships programs in India are given at several institutions, and you can see here that about 36% of the group, that's over 1/3 of the group, had some form of fellowship training, whether it was less than 3 months or more than 6 months. So the next question that we asked was in terms of how IACI played an important role. What role did IACI have in terms of their education? So we, as you know, in the Indian Association of Cardiac Imaging, we have annual conferences, we have midterm conferences, monthly webinars, online meetings, journal clubs, Google Meets. These are some of the different types of educational materials that IACI provides. And 3/4 of the group felt that the annual conference was the most helpful to them. About 60% of the group felt that the midterm conference was also helpful to them, and they were allowed to pick multiple choices in this particular subsection or in this question. And 60% also learned a lot from these online meetings, which our secretary Priya has been doing assiduously and effectively. There were no people who basically felt that they did not attend because it was not useful to them, and a few of them felt that they might find this useful in the future. 2.9%. This is just a small snapshot of these different CMR activities that were performed last year. The Nagpur conference was a purely adult CMR conference, and as you can see that we did target consultants more than residents in this particular group. The Mumbai Vadia conference, which was superb and combined cardiology, pathology, radiology, and artificial intelligence, had a mixture of consultants and residents as part of the attendees. And the Jaipur group, which had a combination of both CMR and CT at a slightly more basic level, was predominantly focused towards residents. If you look at whether the respondees felt that IACI does contribute to their professional growth or their personal growth and circle of peers, we had a positive response, which is on similar lines to how IACI contributed to their educational growth as well. And you can see that about 3/4 of the group felt that IACI was helpful in professional improvement. About half of them felt that their peer interaction was helpful to them, and about 1/3 of them felt that they did learn something from this combination of IACI, the professional or personal growth. We also asked them whether they would be interested in joining committees within the Indian Association of Cardiac Imaging. And part of this reason is, I think one of the things that we could do better as we move forward is to open up different committees and give more opportunities to our members. Interestingly enough, about 17% were too busy to be part of a committee, to offer to be part of a committee. And this is not too unusual, because the Indian way of doing radiology is to combine both CMR and diagnostic imaging, neuroradiology, musculoskeletal, interventional. So the Indian radiologist does have his or her hand in multiple different pies, and this is perhaps the group which is the most busy. But there were many people who wanted to participate in education, 60%. People wanted to participate in credentialing, that is developing the Indian Association's ability to give level 1, level 2, and even level 3 certification courses, or at least accreditation, similar to what SCMR has been very successful in doing. And about another 40% wanted to be part of the scientific committee and be part of the planning. Interestingly enough, and again something which is good for us to note, is that about 1/3 of the group were happy in participating in advocacy, in electronic communication media, and also in terms of membership recruitment. In the last minute or two, I would just share with you some of the suggestions. And these were open-ended suggestions. They could fill up whatever they wanted, and I've tried to group the suggestions together in this particular slide. And you can see that digital learning seems to be something that a lot of people are asking for. More effective use of web-based learning, more newsletters, online repository of cases and lectures, and also certification courses. Again, extended virtual attendance to conference, increased number of conferences. Some even asked for daily one-on-one cases as well. Interestingly enough, one comment suggested that we focus so much on ischemic heart disease all the time that we really should be doing cardiomyopathy first and then do ischemic heart disease. Interesting question. There were some neutral comments as well, and I'm sharing these as well. One comment was that we should have a more professional approach. I'm not quite sure what that means, and hence the smiley face, but something that we should basically think about. There was another comment which said that we were very good in what we did, but we did not offer much opportunities. And hopefully what I've shared about committees is going to help us give more opportunities to members. In terms of current needs, if you just look at different overall headings, you can think about it as workshops. And the workshops that were requested were basic workshops, advanced workshops, increased frequency, increased training for certain examinations such as the CBCMR. Interdisciplinary meetings with cardiology and both online and offline webinars and quizzes was also requested. The ability to join observerships and the ability for us to be guideposts to the remaining population or members of in India by having Indian guidelines, Indian databases, and having more active state chapters is something that was also requested. So in summary, I hope I've shown you that IACI has been effective in promoting CMR in India, and that while we've had many successes, we should also look to our own members and listen to their specific needs so that we have opportunities and directions in which to grow. All for one, and IACI for all. Most importantly, we would not be able to do a lot of what we're doing here at this stage without the active contribution of our friends and well-wishers from the SCMR, and I thank you for being part of our journey. Please enjoy the rest of the conference. Thank you again for your attention.
Thank you, Sanjaya, for that lovely talk. And you have 5 seconds to answer one question. Anyone wants to ask a question?
Looks like I'm saving you 5 seconds, Elizabeth, for questions, huh?
Yeah, that's a joke, by the way.
No, I'm kidding.
That's a leftover from the previous session. Hemant, do you want to ask something? Nori? No? Shall we move on to the next session?
So let me ask my own question and give an answer in that case. Elizabeth, can I do that?
Yeah, sure.
So this is because the previous speaker's comments was very interesting, and I think there is still a lot of work that IACI can do along those lines as well. And also in doing high quality CMR, we need to actually have a program which takes into which allows for hands-on development and workstation and at a console. So I think my survey is far from complete. I'm still working on it. We're still waiting for more responses. And we need to also understand the referral base. And I think IACI can work towards conducting or expanding the survey to understand that. And from what little I could take home from the survey and from the comments that I heard from the previous session, I think we need to sort of incorporate IACI's requirements and goals and vision along with individual members requirements to ensure that CMR is done properly in India, regardless of which country or which city or which state it is performed in. So that's the final comment that I would like to make here. Thank you.
Okay, thank you. Let's move on to the next session.